Okay, our next presenter is John Searles. He is the Substance Abuse Research and Policy Analyst and the Chair of the Vermont Epidemiological Work Group for the Division of Alcohol and Drug Abuse Programs with the Department of Health. Please welcome John Searles.
Really, Ted, after lunch and after Joanne, and I have to give a talk called Epidemiological Data. Thank you very much. Yeah, I thought you liked me. All right, is there a click? Oh, here's the clicker. Let me give some credit to a coworker of mine, Shayla Livingston, who put some of this together. She's a tremendous resource we have at the Department of Health. She works in health surveillance and does a lot of this work with me. We're going to talk about, I can't see a thing from here, actually. So we're going to talk about 7 main sources of epidemiological data: the Youth Risk Behavior Survey, the National Survey on Drug Use and Health, the Behavioral Risk Factor Survey Surveillance System, some statewide hospital and emergency data, data from the Vermont Treatment System, and the Drug Abuse Warning Network, if I have time for that, and some other data I think hopefully will be of interest. The Youth Risk Behavior Survey, I'm sure you're aware of the fact it's done every 2 years. We collect data on 9th through 12th graders as well. Now we also collect data on 6th through 8th graders. It's one of the best surveys of this type in the country. I think Vermont collects more data on more students than anybody else in the country in terms of coverage. So we have a lot of confidence in these data, and we're going to be talking about that for a little bit. Oh, I forgot to tell you, this is my orientation. The subtitle is, "Are you just pissing and moaning, or are you," what does it say? I can't even read it. "Can you verify data?" So this is how I live my life with data, as my children will tell you from the daily statistical briefings I give them. So this is the YRBS data for 9th to 12th graders for lifetime use in Vermont for all the substances that we measure. The red stars are significant reductions from 2011 to 2013. But as you can see, we're going in the right direction in terms of substance use prevention for 9th to 12th graders. This was a question we just started asking this year: texting or emailing while driving in the past 30 days. This is terrifying. 11th graders, it's 42%, and for 12th graders, it's 56%. And this is without the alcohol and drugs. So this is something that just I think is going to be a problem in the future, if not now. And why do we worry about adolescent decision-making process? Well, this is a little cartoon I find. It says, "Jeremy, what happened?" He said, "Pierce threw me down the stairs. Good Lord, what were you doing? Trying to throw each other down the stairs." So that's kind of an encapsulation of the adolescent decision-making process that we're trying to influence. This is the past 30-day marijuana and cigarette use from the 2013 by county. A couple of things I wanted to point out here. One is that marijuana use is higher than cigarette use in Vermont for 9th to 12th graders. And there are no statistical differences across counties in use of marijuana or cigarettes in Vermont. If I go through this too fast, let me know. This is prescription lifetime use of prescription drugs. This includes both opiates and stimulants. And just like in 2011, in 2013, Windham County was significantly greater than any other county in Vermont. We don't know why, so if you have any suggestions, please let me know. This is past 30-day prescription drug use this is another new question we asked, which is 30-day prescription drug misuse. And again, Windham County is the highest. This is the first year we've asked the 30-day question. The previous one was a lifetime, but so we don't know why it's so much higher in Windham County. And this is relevant to the conference today, I think. Driving after drinking or smoking marijuana, and as you can see, driving after smoking marijuana has always been higher, or at least reportedly higher than driving after drinking. And then the last administration, although that's a significant increase, there was a change in the way the question was asked, so it's probably not as significant as it looks. But the important thing to note here is that this survey shows that students report driving after smoking marijuana greater than they do driving after drinking alcohol. And this is riding with an impaired driver, either alcohol or marijuana. Again, marijuana shows a higher rate of incidence as long as we've been tracking it. I guess the good news is it's going down slightly, but that probably will flatten out given recent cultural changes in our society. This survey, the Behavioral Risk Factor Survey System, is a random digit dial survey for adults 18 and over. We don't have a lot of good data on the younger part of this sample because the mean age is 47 years old. We added marijuana and prescription drug questions in 2007. And there are obviously some issues with our younger group because of the cell phone issues. I don't know about you, but my kids don't have home phones. They only have cell phones. So they're doing some adjustments to the data and how they ask the questions and how they who they random digit dial through cell phones. There are some issues about who pays for the call, but this is a government survey that's also being adjusted for these kind of issues. This is alcohol use in the past month from the BRFSS. This is comparing Vermont to the U.S. data. We're higher throughout since the survey has been asked. And this is binge drinking in the last month, and things are not looking good for the last administration of it, which was the last data we have that's analyzed is 2012. Marijuana use in the BRFSS, again, this is ever is the top green line, and the past 30 days is the bottom turquoise line. And we didn't ask the ever question for the last administration, just because we can't ask all these questions every year. Otherwise, the survey would be about 300 pages long. So we kind of select which questions we ask at which administrations. But as you can see, from 2011, the data don't look very good in terms of marijuana use ever. And this is a number of, this is the estimate of the actual number of reported driving under the influence of alcohol and marijuana. And as you can see, for a long time now, since 2008, the more people report driving under the influence of marijuana than they do under the influence of alcohol. Again, I think this is going to get worse as we progress. Well, this is the study that Dr. Roberts already talked about, so I guess I won't go into this. But the bottom line here is that marijuana, finding marijuana in fatally injured drivers has almost tripled since 1999. And this is the percentage of persons age 16 or over driving under the influence of illicit drugs in the past year. As you can see, Vermont's in the top ranking here, in the top quintile of states. Prescription drug use among adults, again, this is the BRFSS, and this is ever used is the blue bar, and I can't tell if that's green or black, is the past 30 days use. And it's been very steady for the last 5 years since we've been asking the question. The National Survey on Drug Use and Health is actually one of our gold standard surveys. It's a representative sample of both nationally and in each state. They survey civilian, non-institutionalized populations age 12 or older. As you mentioned, and one of the reasons they do 12 or older is because they want to get 12 to 17, as we'll see. These are face-to-face interviews, except when it comes to sensitive questions, it's computer assisted. That is, they have the kids, or everybody actually, put on headphones, and so there's no face-to-face interaction with the interviewer at that point because they want to make sure they get as accurate data as possible. In 2011, across the country, they interviewed 67,500 respondents, so we're pretty confident that these data are accurate. Okay, these are the trends by substance and age group. This is Vermont, so for 12 to 17 is in the blue line, 18 to 25 is the red line, and 26 plus. And this is alcohol use. And it's the reason it's 2002 and 2003 and 2011 and 2012 is they have to combine the samples for a state as small as Vermont, so we get the data every 2 years broken out by these age groups. And again, as you can see, it's been very steady since 2002. This is binge drinking, again, broken out by age groups. And again, it's been pretty remarkably steady for the last 10 years. This is 30-day marijuana use. 18 to 25-year-olds are increasing. Not significantly so yet, but we'll see what happens in the next couple administrations of this survey. This is we compared Vermont to the rest of the country. We are statistically higher in terms of past year use of marijuana for every age group: 12 to 17, 18 to 25, and 26 plus. And note that almost half of the half of the population of 18 to 25-year-olds have used marijuana in the past year. This is the percent of Vermont population using non-medical use of pain relievers in the past year. And again, this is a relatively steady and slightly decreasing prevalence rates. The 12 to 17-year-old rate compared to 2002 is a significant difference in 2011 and 2012. That is, it's significantly less than it was in 2002 and 2003. This is a percent of the Vermont population who needed but not received treatment for alcohol problems in the past year by age group. We're making pretty good progress in this area. The way this question is asked is this is a DSM-4 question, which is if you meet criteria by answering the criteria questions that are in the Diagnostic and Statistical Manual, which is the way that people are diagnosed, and then you're not in treatment. This is why you get on this chart. I just wanted to point out that about 95% of individuals who reported they didn't need treatment said they didn't feel they needed treatment. So this is, my deputy commissioner pointed out, is still an access issue because some of these people may not think they need treatment, but they do qualify for a diagnosis. And this is an issue that we need to try to get these people in treatment before they get into deeper trouble. This is data on drug deaths from the Office of the Chief Medical Examiner, and I think the data are pretty clear. There's been a fairly steady rate. We only have, I thought I had updated this slide, but apparently not. For 2013, there were 21 heroin deaths. Is the heroin on here? I can't even see which. Oh, this is a different one. I'm sorry. This is male versus females. So this is drug deaths in Vermont, updated to 2013, and there were 21 heroin deaths in 2013. So it did more than double from 2012. So we are certainly looking at a serious problem here. The VPMS is the Vermont Prescription Monitoring System. This will probably goes along with what Joanne said about the number of prescriptions that are being given out from as tracked by the VPMS. The total number of prescriptions in Vermont from the fiscal year 2012 was over 1 million. And this is scheduled drugs, that is, drugs that are controlled substances. And these are the actual numbers in terms of broken down by category of drugs: opiates, sedatives, stimulants, opiate partial agonists is things like buprenorphine, and then I can't read the last one. Anticonvulsants, okay. This is the number of prescriptions by gender, the percentage of prescriptions by gender, and more females than males get controlled substances in Vermont. Percent of all prescriptions by their therapeutic class differ by gender. The opiates are more males than females, and sedatives are more females than males. And stimulants, which again are your ADHD drugs and other drugs in that category, are mostly male. And this is the age distribution for the scheduled drugs that we track in Vermont. Again, broken down by gender, so it gets worse as you get older. This was an original concern of some individuals, or of a lot of people actually, that thought that there were other people other than physicians who were prescribing drugs that were getting out on the streets, particularly dentists, I think, and this kind of shows that that's not the case. Most of the prescriptions, 3/4 of them are done by physicians, and then another 10% by physician assistants. Advanced practice nurses are physician assistants. So almost 95% of the drugs are by providers. Hospital and emergency room data. This is alcohol-related diagnoses, and again, this is males and females, and probably no surprise, males have a much higher rate of emergency room discharge rates for alcohol than do females across the number of years we're tracking. Again, this was emergency department discharge rate per 10,000. Again, for all 4 classes of substances that we track, and as you can see, alcohol by far is the highest rate of emergency department discharges across the years, and I have no explanation as for why it went down so dramatically in 2010, except for the fact that I don't think we have some of the out-of-state data for 2010. There's been some issues. By out-of-state data, I mean Vermonters who were seen in New York, Massachusetts, and New Hampshire. Some of those data are not yet available. This is emergency department discharge rate per 10,000 for females. Again, alcohol is the leading drug, followed closely by opiates with an increase from 2005 on. And this is the Vermont emergency discharge data rate per 10,000 people. These are overdose rates. Again, very steady rates. Nothing has changed much since 2002. They're pretty much flat lines across the board. And again, this is for opiates and sedatives. Hospital discharge rate per 10,000 people for overdose by drugs. There is a slight uptick in sedatives in 2010. And again, this is the latest data we have from this data set. So it's still 3 years old, but this is as good as it gets. The treatment episode data set tracks data from all treatment episodes. This is national data, actually. And as you can see, if you look at the green line, that's a sum of heroin and prescription opiates. And that shows that opiates are on the rise in treatment. And we'll talk about that in some more detail in a minute, looking at more Vermont data. This is the this is the Burlington Take-Back Day data for distribution of scheduled versus non-scheduled drugs. You'll remember that 2 or 3 times a year, the Drug Enforcement Administration sponsors take-back days where people come and drop off their drugs. And as you can see, most of the drugs that are being dropped off are not scheduled drugs. So we hope to increase both the percentage of scheduled drugs being dropped off and also the number of places where we can access these data. This is from our own treatment data, and as you can see, opiates are tremendously increasing from 2000 to 2012. I don't think this comes as any surprise to anybody. That's where the problem lies in the treatment system, people requesting treatment. And this is what's happening. Everything, alcohol is going down, and all others are pretty flat. However, for adolescents, the number one drug of choice in treatment is marijuana. Again, it's decreasing, but as you can see, in the last year, in 2012, it started to increase again, and we're going to follow this pretty closely. I won't get into that. Okay, this is data from the Northern New England Poison Center, and I show you this slide because this tracks the number of calls by substance that the Northern New England Poison Center gets. And the reason I wanted to show you this is the number of calls has significantly decreased from 2011 to 2013. So again, they have no explanation for this, and we don't either at this point, but it's pretty interesting, and as well, also the calls for opiates have decreased significantly since 2011. This is the change in Vermont crime rate from 2000 to 2010. This is based on the UCR data. All the crime rate categories, major categories, have decreased, although my understanding from talking to some law enforcement individuals and also from data individuals associated with these data is that it's been increasing in the last few years, but I don't have those data at this point, so we'll see where that goes in terms of drugs and crime. The Drug Abuse Warning Network is a national network that reviews all ER cases, and they get a sample of all 24-hour emergency rooms. They're record reviews, they're not patient interviews. They have a very strict protocol so that the records from different venues are comparable, so you can look across venues and see what's going on. And it covers all aspects of drug use, including suicide attempts, accidental ingestions, and drugs as a direct or a contributing cause of an ER visit. And this is the Drug Abuse Warning Network data. This is national data by age. The yellow line is alcohol. The purple line is marijuana. The red line is opiates, and the green line is cocaine. The alcohol that's underage drinking for the most part for the 18 to 20-year-olds. But as you can see, again, marijuana is one of the highest for those under 25. And opiates peaks at 25 to 29 and then starts to go down. Cocaine continues to rise until age 45 to 54. I just chose these cities just to show you what the rates are by city for alcohol, and I think I have a couple more of these. Hang on a second. If I could, New York is highest in alcohol, followed by Denver, and then I have. All right, I can't read this. Is that Minneapolis? Yeah, Minneapolis, Boston, Seattle, and then the U.S. data, and they're in the gray. These are heroin rates by city. New York is number one, if you want to call it that way, but it has dropped and has leveled off from 2009. Marijuana rates. This probably comes as no surprise. Denver is the highest and continues to climb. We'll be interested to see what kind of data Seattle provides in the next few years. And this is the prescription opiate rates. And this is, for some reason, Seattle was the highest for a while. Now it's Boston. Cocaine rates, again, no surprise. It's New York. Again, there was a tremendous drop-off in a few years ago, but that also has flattened out. This is an interesting comparison that I did because of the methamphetamine, awareness that we had in Vermont. So I took 4 cities from the east, New York, Boston, Detroit, and Chicago, and compared them with 4 cities from the west, Denver, San Francisco, Seattle, and Phoenix, just to see what the rates were over time. And as you can see, the 4 cities from the east, which are all scrunched up in the bottom, the methamphetamine rates are flat and extraordinarily low, while the states from the west have very high rates. And so essentially the methamphetamine never got east to the extent that everyone thought it was, at least in terms of the dawn rates. These are total hospital charges for alcohol and illicit drug use, inpatient and emergency department charges. Drugs and alcohol are expensive in our healthcare system, and this quite explicitly demonstrates that. This is for both abuse and for dependence. And then I wanted to talk about alcohol and drug abuse programs. Our budget for 2012 is heavily weighted toward treatment, although we do have a lot of studies that show that for every dollar spent on prevention programs, it saves about $10 to $16 in long-term costs, such as healthcare, criminal justice, lost productivity. So this is my pitch for putting more money into prevention. And here's another, the cost per client by type of service. Outpatient and intensive outpatient services cost about $1,000 per client, whereas residential treatment costs about $5,000 per incident per client. And we've got research that shows that there's no difference in outcomes, although I will qualify this by saying there's a lot of variables that go into this. So I'm not suggesting that everyone should have outpatient treatment. It's just that most of the studies that compare these treatment differences in venues show that the outpatient and inpatient treatment have about the same outcome, but that the outpatient treatment is significantly cheaper. This also depends upon a lot of characteristics such as social supports, homelessness, and things of that nature that require some that require residential treatment, and also the seriousness of the addiction. Okay, I'm not going to go in. I thought I'd erase this, so let me just. We did our state epidemiological profile in 2007 for our strategic prevention framework state incentive grant, and this is what we found out was our prevention priorities for that grant: underage drinking, high-risk drinking for those under age 25, which is binge drinking, and marijuana use for those under age 25. And then we revisited that last year, and again found that the three priorities for prevention were underage drinking, high-risk drinking for those under age 25, and marijuana use for those under age 25. However, we're also watching cocaine, because Vermont is #1 in cocaine use among 18 to 25-year-olds. We're obviously watching prescription drug misuse, and we're very concerned about some of the new synthetic drugs, although those don't seem to be as big a problem as they were predicted to be, probably because we got a good handle on it very quickly and passed some very good legislation about this. So we're actually ahead of the curve on this. And we're also, one of our priorities is alcohol consumption among pregnant women, which has all kinds of serious consequences. And as we want to say that there is no dose of alcohol that is not harmful that we know of. That is, there is no minimum dose of alcohol you can take that's not harmful to a fetus. At least there hasn't been any research that suggests that there is. Just want to make sure we're paying attention to the right things in our data. So that's all I got.